Hey everyone, welcome back. This is Dr. Dilip, your medicine faculty from Cerebellum team, and today we're going to have a quick discussion overview of all the medicine questions that was asked in the recent May 2024 INI paper. And I've organized the question system-wise so that it will be easier for you to revise in the future. And first we'll be starting off with cardiology, then we'll be moving on to the other systems. And before starting the discussion, I would like to say that they have literally covered all the important domains in this paper. Plus at the same time, I'd personally rate this paper to be a moderate to difficult one, because even though certain questions appear to be simple, straightforward, one-liners, but they are actually not. Certain questions were really tricky, especially when it comes to the core medicine part. Let us move on to the discussion. As I said, first I'm going to start my discussion with cardiology, then we'll be moving on to other systems. Here is your first question. A 55-year-old man present with chest pain and shortness of breath. ECG was taken in emergency and was shown. What is the likely diagnosis? To be honest, if you do not have cardiac troponins or any other cardiac biomarker for that matters, it's virtually impossible to differentiate between NSTEMI and unstable angina. In fact, the only way to differentiate NSTEMI versus unstable angina in practice is by looking at the cardiac troponins. In case if the troponins are positive and if the clinical history is compatible with ACS, and if you don't see ST elevation in the ECG, you call it as NSTEMI. In case if cardiac troponins are negative and if the clinical history is compatible with ACS, and if you don't see ST elevation, you call it as unstable angina. So virtually the only thing that separates NSTEMI and unstable angina in practice is the troponins. Here the troponins are not mentioned, so I can easily rule out NSTEMI and unstable angina. To be honest, you will not be able to differentiate NSTEMI versus unstable angina in ECG, as simple as that. And what about acute myocarditis? Acute myocarditis should have some relevant history, at least in exams. Like for example, patient will have some history of viral prodrome like URI, followed by that they should have developed either heart failure or rarely ACS-like feature, but here there is no history that is compatible with the diagnosis of acute myocarditis. And the ECG changes in acute myocarditis will be quite non-specific. They can produce ST changes, they can produce T wave changes. In fact, one of the most common changes that you see in acute myocarditis is sinus tachycardia. So I don't think that's going to be the possible answer here. And the only thing that's left is post-AMI, and yes, that's the right answer for this question. And if you look at the ECG in V2, V3 especially, you're able to see the characteristic feature of post-AMI in a standard 12-lead electrocardiogram, that is the tall R wave with ST depression and an upright T wave. This is so characteristic of post-AMI in V1, V2 or probably V3. So here you're seeing typically in the V2, V3, right? So most of the times post-AMI will be associated with inferior MI, but sometimes posterior MI can come without inferior MI. That is called as isolated posterior MI. And if you look at 2-3 AVF, possibly, yes, I still feel there is some inferior MI over here because there is a slight bit of elevation 3 in AVF, but I'm not able to confirm here. So because it's not classic, but what is so classic here is the posterior MI for sure. Even though ultimately you can diagnose posterior MI only by looking at V7, V8, V9, which are the posterior leads. But in this case, here at least, there are no posterior leads mentioned, only V2, V3, you have to make a diagnosis. So remember, in case if you're taking posterior leads, that is V7, V8 and V9. So what you're going to see in a classic fully evolved STEMI is a kind of a Q wave along with a convex ST elevation and a T wave inversion. This is what you're going to see in a fully evolved STEMI if it's a posterior MI in V7, V8, V9. But because you're not taking V7, V8, V9 in the beginning and you will be relying on V1, V2, V3 to suspect posterior MI, what you'll be seeing is just a flip. That's a mirror image of what you see in the posterior, because what you see in the posterior is Q wave, ST elevation and T wave inversion, and just flip it around and you will get what are the changes that you're going to see in V1, V2, V3. So that's nothing but an upright R wave or a big R wave. Along with that, you're going to see an ST depression and you're going to see a upright T wave as well. So this is the classic pattern that you see in V1, V2 plus or minus V3 in case of a posterior MI. And that is what you're seeing in this ECG as well. So this is a classic to classic posterior MI. So the right answer for this question is option C. And we have discussed this n number of times in our regular videos. We have discussed this in QR and we have also discussed in our mission videos. So I don't think you should be able to find this question difficult. Coming to question number 2, a young male present with palpitations, hence ECG was taken. ECG demonstrated narrow complex tachycardia and BP is 70-40 millimeters of mercury. And what is the next step in the management of this patient? So this is something that's been asked hundreds of times in multiple different exams. Even in a lot of our GTs, we have asked this question so many times. When the patient is unstable and if you have a pulse, the treatment is shock, as simple as that. So when the patient is in shock, treatment is shock. We have discussed this mantra so many times. So the right answer for this question is going to be synchronized DC cardioversion. In case if the patient doesn't have a pulse and if you have a VTVF situation, then you can go for asynchronized cardioversion, that is called as defibrillation. But here the patient is having a pulse and a recordable BP at least. So definitely here you have to go for only synchronized DC cardioversion. IV adenosine 6 milligram and carotid sinus massage, I could have probably tried in a regular narrow complex tachycardia provided the patient was stable, but here the patient is unstable, so I cannot choose those options. And what about IV amiodarone? IV amiodarone is something that's preferred in a stable wide complex tachycardia, especially if it's a monomorphic regular wide complex tachycardia, then definitely IV amiodarone is going to be the best treatment in that case. So the right answer for this question is a simple, straightforward synchronized DC cardioversion. Going to question number 3, a 45-year-old female with history of chest pain and upper respiratory tract infection 7 days ago, presents with shortness of breath. She has a BP of 100 upon 60 millimeters of mercury and pulse rate is 110 beats per minute. So patient is in tachycardia. Chest X-ray shows an enlarged heart which appears like a water bottle. So they're likely talking about a pericardial effusion. Which of the following is incorrect? So here the patient is likely to have developed an effusion and probably a tamponade because of a viral infection in the past. So that's what the history is suggesting. And what are the features of your cardiac tamponade? Pulsus paradoxus is usually seen. Yes, that's a right statement. Pericardiocentesis may be required, especially if the patient is hypotensive or if the patient is having high JVP. Definitely pericardiocentesis is required. There is no doubt about that. And option D states echo will show diastolic RARV collapse, which is a classic feature of a tamponade in your echocardiogram. In fact, this confirms the tamponade because during diastole, the right atrium and right ventricle should basically expand, but because of the effect of fluid around the heart, they tend to collapse in the setting of tamponade. That confirms the physiology of tamponade, so that's also a right option. So what is wrong here is a straightforward option C, because you don't see loud S1 when it comes to effusion and tamponade. In fact, you see muffled heart sounds, which is a part of the Beck triad, which states you have hypotension, jugular venous distension, and muffled or distant heart sound. So you don't see a loud S1, rather the heart sounds will be muffled in case of cardiac tamponade and effusion. So right answer for this question is going to be option C. Then moving to question number 4, which of the following is incorrect regarding high quality CPR? So they have literally asked everything about chest compression. Chest compression should be at a rate of 100 to 120 per minute, not more, not less. This is perfectly right. Correct statement. Allow adequate chest recoil, because if you don't do that, then the diastolic filling of the heart will be very poor. So you have to wait for adequate chest recoil. And chest compression to rescue breath ratio in adult is invariably 30:2. If you don't have an advanced airway, that is again straightforward and it is true. Depth of compression must be 3 to 4 centimeter. Absolutely, it's wrong, because depth of compression is around 5 centimeter, that is 2 inches. So the right answer for this question is again a straightforward option D. Coming to 5th question, this is a little tricky, but still you can solve it. A 38-year-old man collapsed and was brought to emergency. ECG was taken and a diagnosis of atrial fibrillation was made. Which of the following is true? If you look at the ECG, it's simple, straightforward. You're seeing an irregular rhythm without any formed and repeating P waves. So definitely this is a case of atrial fibrillation, no doubt. And in fact, they have simplified the question by already giving the diagnosis of atrial fibrillation. So they're asking which of the following is true. So you have to identify the true statement. Option A states almost never seen in heart with normal morphology is a wrong statement, because depending on the study you are going through, 15 to 35% of atrial fibrillation can occur in a morphologically normal heart. Yes, even though AF is very common in a structurally abnormal heart, especially in case of heart failure or left atrial enlargement, but it can be seen in patients with morphologically normal heart as well. So that's a wrong statement. DC cardioversion is required in all cases is also wrong, because in acute situation, DC cardioversion is required only if the patient is unstable, or probably in chronic situations, if you are planning for rhythm control and if you want to do cardioversion, then you can do electrical DC cardioversion. But it's not generally required for all cases. In fact, rhythm control in chronic atrial fibrillation is required only in selected cases. We have discussed that so many times. So that's also a wrong statement. And option D states discrepancy in heart rate and pulse rate, which is nothing but pulse deficit is a clinically reliable criteria for diagnosis. Again, this is a wrong statement. Even though traditionally, historically, pulse deficit of more than 6 to 10, that is, if the pulse rate is lesser than the heart rate by around 6 to 10, you can probably make a diagnosis of atrial fibrillation. But it's not a clinically reliable criteria for diagnosis, because it can be seen in so many other conditions, like for example, ventricular premature contraction, especially if it's frequent. And you might be able to see that in cardiac tamponade also, sudden cardiomyopathies and severe heart failure also, you might be able to see that. So that is not a very reliable criteria for diagnosis. What about option B? Option B states IV digoxin can be used for ventricular rate control, which is a perfectly right statement. So we have discussed so many times, if the patient is stable, then for purpose of rate control, you can use certain drugs. For that, you have to see first whether the patient is in acute heart failure or not. If the patient is in acute heart failure, then the treatment of choice will be digoxin, and you can give IV digoxin also for this purpose. And if the patient is not in acute heart failure, then you will be sticking on to either a beta blocker or a non-dihydropyridine calcium channel blocker like verapamil or diltiazem. We have discussed this a number of times. So option B is the right answer for this question. Let us move on to sixth question. It's an assertion reason kind of a question. Assertion is that myocarditis is seen as a complication of diphtheria. Perfectly right. It's one of the most common cause of death in diphtheria. Reason it is due to bacteremia. It's wrong, because diphtheria causes problems because of the toxemia, and not bacteremia. So in this case, the assertion is true, but the reason is false. As simple as that. So let us move on to the next question. Which of the following is a PCSK9 inhibitor? And again, we have discussed tons of times. There are only two PCSK9 inhibitors which are very commonly used in modern practice. That is evolocumab and alirocumab. Right answer is option A. Ezetimibe is basically a NPC1L1 transport inhibitor, or we can say it's an intestinal cholesterol reabsorption inhibitor. And evinacumab is a modern drug ANGPTL3 inhibitor, which is typically approved for cases of familial homozygous type 2 hyperlipidemia. And everolimus is basically an mTOR inhibitor. It is an immunosuppressive drug and it has nothing to do with dyslipidemia. So right answer for this question is option A, evolocumab. Moving to question number 8, which of the following anticoagulants require coagulation profile monitoring? To be honest, this is a kind of a tough question for a candidate to have read Harrison well, because we know every single anticoagulant can somehow be monitored. But let us assume the question is about what anticoagulants require routine coagulation profile monitoring in clinical practice. Obviously, lepirudin. It's a parenteral direct thrombin inhibitor. We have 4 parenteral direct thrombin inhibitors like lepirudin, hirudin, bivalirudin, and argatromin. All of them can be monitored and has to be monitored with something called APTT, that is activated partial thromboplastin time, or simply PTT. And bivalirudin alone, especially if you are giving in cath labs, at high doses, you have to monitor with ACT, active clotting time, rather than APTT. That also has to be kept in mind. And what about option A and C, enoxaparin fondaparinux? The biggest advantage of enoxaparin fondaparinux compared to UFH is the fact that these drugs are very reliable and predictable in their action. So you really don't need monitoring under routine circumstances. But in special situations, clinical practice, you may need to monitor them with the help of something called as anti-factor 10A activity. We have discussed that so many times. And what about dabigatran? Dabigatran comes under something called DOAC. We have 4 DOACs. Dabigatran, which is a direct thrombin inhibitor, and we have the 3 other factor 10A inhibitors, which are apixaban, rivaroxaban, edoxaban. These drugs are very reliable and predictable in their action, unlike warfarin. That's the reason why these drugs need not be monitored routinely. But if you need monitoring for dabigatran, you can do that with the help of same APTT, because it's also a direct thrombin inhibitor but an oral drug. And if you want accurate monitoring of dabigatran, then APTT will not be enough. You have to go for some special assays like dilute thrombin clotting time or probably Icarin clotting time. So we're not going to talk about that right now. Right answer for this question is a simple, straightforward option B, lepirudin. Coming to question number 9, which of the following connective tissue degradation disorders associated with aortic aneurysm? So whenever Marfan syndrome is there in the picture, I'm not going to choose anything apart from that, because it's a typical connective tissue degradation disorder that's going to be associated with thoracic aortic aneurysm especially. And what about Ehlers-Danlos syndrome? Yes, one type of Ehlers-Danlos syndrome, that is the type 4 vascular type of Ehlers-Danlos syndrome, can cause aortic aneurysm and aortic dissection. But comparing with Marfan syndrome, I'll go for Marfan syndrome only. What about atherosclerosis? Yes, it's a risk factor for your abdominal aortic aneurysm, but definitely, like when it comes to again Marfan syndrome, I'm going to go for that only. What about scurvy? Scurvy is again a kind of a collagen disorder, but it is not associated with aortic aneurysm, by the way. It's going to only produce like mucosal bleeding and all those things. So I'm not going to go for scurvy as well. The right answer for this question, 100% undoubtedly, is going to be Marfan syndrome. What about question 10? A 45-year-old patient with a penicillin allergy presents with enterococcal endocarditis. Which are the following drugs that can be safely used in this patient? Remember, enterococcus is a gram-positive organism. And I think we have discussed a lot of times about how to treat enterococcus in an algorithmic fashion in our extra advantage sessions as well as in the mission videos. I told you, whenever you are having a possible enterococcal infection, the initial cover must be with penicillin. So ampicillin is likely the first line drug of choice in any enterococcal infection. Suppose if the patient is having penicillin resistance or ampicillin resistance, or if they mention penicillin allergy, then I cannot use ampicillin. So then the next ideal drug will be vancomycin. But if the question mentions vancomycin resistance, So if there is a vancomycin resistant enterococcus, then in that case, you have to go for either linezolid or tigecycline depending on the site of infection. Tigecycline is typically approved for complicated skin and structure infections and probably a complicated intra-abdominal infection as well. So apart from that, usually we prefer linezolid, or sometimes you can prefer even other drugs like daptomycin also, which I'm not going to talk about that right now. So this is the algorithm for treating enterococcal infections. So here they've clearly mentioned penicillin allergy. So in that case, I'm going to go for vancomycin. The right answer for this question is option B. Why not aztreonam? Aztreonam may be used in patients with penicillin allergy, but if you want to have a gram-negative cover, for that you can use aztreonam. Typically in exam, if they give a history of pneumonia, especially a community-acquired pneumonia, and the patient is in ICU, and if you want to give a beta-lactam, but the patient is having history of penicillin allergy, then in that case, aztreonam will be the best choice. All right. So what about question number 11? Which of the following is the least common cause of bipedal edema? Again, we have discussed that so many times venous problems like deep vein thrombosis, chronic venous insufficiency, most of the time you're going to have an asymmetric leg swelling. One side will be involved more than the other. So if you don't have a symmetric bipedal edema, most of the time will be unilateral, or even if it's bilateral, it's going to be asymmetric. So chronic venous insufficiency is typically going to produce a unilateral rather than a bilateral edema. So lupus nephritis, yes, it's a kidney problem. It produces bilateral edema. And heart failure, again, it's a systemic problem. It's going to produce bipedal edema. Chronic liver disease, again, is going to be a systemic problem. It's going to produce a bipedal edema. Going to the next system, that is endocrinogen metabolism. Here is your first endocrine question. Many G protein coupled receptors act via increase in cyclic AMP, which means they are talking about the G stimulatory pathway. The steps involved in the mechanism are given below. Which of the following is the correct sequence of events in the cyclic AMP signal transduction pathway? So what are the steps involved in G stimulatory type of GPCR? First, the ligand has to bind with the receptor. There are a lot of ligands that bind to G stimulatory GPCR. And once the ligand binds with G stimulatory receptor, it's going to activate it. And the substrate for activation is going to be adenylate cyclase. Once adenylate cyclase is activated, it's going to convert ATP to cyclic AMP. The cyclic AMP levels is going to increase. And this cyclic AMP is going to activate another downstream protein called as protein kinase A. So this protein kinase A is going to cause phosphorylation of target proteins. So this is going to be the exact signal transduction pathway when it comes to G stimulatory type of GPCR. So right answer for this question is going to be 1, 3, 2, 4. Simple. Right answer is option B. Moving to question number 13. A 45-year-old man present with weight gain, proximal weakness, purple train, AC bruising. What is the likely underlying condition? I don't think this question needs any further discussion. The right answer for this is Cushing syndrome, which is due to hypercortisolism. Coming to question number 14. All of the following are criteria for diagnosis of diabetic ketosis except. So when it comes to a case of DK, you need to prove the diabetes component, you need to prove the ketosis component, and you need to prove the acidosis component. So diabetes component can be proved by a serum glucose of more than 250, that's correct. So ketosis component can be proved by plasma ketone positivity, it's not mentioned here. And acidosis component can be proved by a arterial pH of less than 7.3, a serum bicarbonate of less than 15 to 18, and an anion gap of more than 12, because ketosis causing acidosis will be a high anion gap metabolic acidosis. Any anion gap of more than 12 is going to be HAGMA. So only thing that's not going to come under the diagnostic criteria of DK is going to be serum potassium of less than 3.5, because even though potassium imbalance is very, very common in a case of DK, it is not basically a diagnostic criteria for DK though. So right answer for this question is option D. It's easy one. Coming to question number 15. It's a kind of an ambiguous question. I'm not sure exactly whether this question was asked in exams or not, but it's a kind of a recall that students told me. A 30-year-old patient present with proximal weakness, lethargy, low depressed mood, and recurrent renal stones. Laboratory testing revealed a normal serum calcium and increased PTH levels, even though some students say it's a low serum calcium. I'm not very sure about that. So what is the organ involved in the pathology? So this is a classic case of primary hyperparathyroidism. There is no doubt about that, because patient is having proximal weakness, patient is having psychiatric manifestation, patient is having recurrent renal stones. It's a case of hyperparathyroidism, and you are having increased PTH levels also in the question. There is no doubt about that. So what about this normal serum calcium? So everyone would have studied that hyperparathyroidism means hypercalcemia. That's true, but there are some cases of hyperparathyroidism which can be normocalcemic. That variant is called as normocalcemic primary hyperparathyroidism. I don't know whether this is the exact question that the examiner has asked or not, but still I wanted to convey there is something called as normocalcemic hyperparathyroidism, where the patient will have a normal serum calcium and they'll have almost all of the clinical features of hyperparathyroidism, and an elevated PTH. But the calcium alone will be normal. That's called as normocalcemic primary hyperparathyroidism. And this is actually a diagnosis of exclusion. This is basically a diagnosis of exclusion, which means you have to rule out all the other causes of secondary hyperparathyroidism like vitamin D deficiency, chronic kidney disease. Those conditions has to be ruled out. Then only you can make a diagnosis of normocalcemic primary hyperparathyroidism. Here, there is no much clinical findings that are in favor of vitamin D deficiency and osteomalacia or rickets. And again, there are no history that is suggestive of chronic kidney disease as well. So I don't think you can make a diagnosis of secondary hyperparathyroidism here to make a diagnosis of bone and metabolic bone disease. So I think the examiner would have expected something called as normocalcemic primary hyperparathyroidism. So I am likely going with option A, that is parathyroid gland and hyperparathyroidism. Coming to question number 16, which of the following drugs used in the management of type 2 diabetes associated with an increased risk of urinary tract infection? This diabetic drugs is something that we have discussed left, right, and center. Even in the marathon sessions, we have discussed so many times. The right answer is SGLT inhibitor, that is dapagliflozin. Pioglitazone can be associated with risk of bladder cancer. Pioglitazone can cause fluid overload and worsening of heart failure, and pioglitazone can also cause macular edema, weight gain. We discussed so many things about pioglitazone. Sitagliptin is a DPP-4 inhibitor, which is basically associated with risk of pancreatitis, and it can cause GI disturbance. And metformin is typically associated with watery diarrhea, we've discussed so many times, and also with B12 deficiency and lactic acidosis. Coming to question number 17, a 55-year-old patient with type 2 diabetes mellitus is being evaluated for medications to manage their condition and prevent renal complications. Which of the following drugs will not delay renal progression in cases of diabetic kidney disease or probably type 2 diabetes? So we know that SGLT inhibitors and GLP-1 receptor agonists are diabetic drugs which can reduce the progression or delay the progression of diabetic kidney disease. And ACE inhibitors and ARBs, well-known drugs, these are basically the drugs of choice in patients with hypertension and diabetes, or probably in patients with diabetic kidney disease with proteinuria. And Finterone is a modern drug. It's a non-steroidal MRA that is also approved for this indication. But what is not going to delay the progression of renal disease in patient diabetes is hydrochlorothiazide. Apart from these three drugs, SGLT inhibitors, Finterone, ACE inhibitors, ARBs, and probably GLP-1 receptor agonists, no other drug has been shown to delay the progression of diabetic kidney disease to end-stage kidney disease. The right answer is option C, hydrochlorothiazide. Moving to question number 18, which of the following drugs used in the management of diabetes associated with unexplained diarrhea? So we discussed time and again that metformin is associated with three important side effects. Just a while ago also we discussed the most important and most common is GI side effect, that is watery diarrhea. Apart from the two other uncommon side effects, that is B12 deficiency and lactic acidosis, but still it's important for exams. Sitagliptin, if you're wondering, it's a DP4 inhibitor. It's an incretin drug. Yes, it can produce GI side effect, but its side effect is going to be more of gastroparesis related, like indigestion, nausea, bloating, and so on. So it's not going to produce diarrhea. So I'm going to exclude that. Let us move to the next question. A 30-year-old patient with heart failure and poorly controlled type 2 diabetes, the A1C of 7.8%, presents with progressive dyspnea, that is worsening of heart failure, which is the preferred anti-diabetic drug. So we know that when it comes to heart failure and reduced ejection fraction, especially a chronic HFrEF, there are 4 drugs that's going to be beneficial. Like for example, you have RNAs and ACE inhibitor ARBs. Even though RNAs are better, then we have the 3 beta blockers, the MBC beta blockers, metoprolol, bisoprolol, and carvedilol. The third one, MRAs. These are mineralocorticoid receptor antagonists or aldosterone antagonists like spironolactone and eplerenone. And fourth, we have the SGLT2 inhibitors, especially empagliflozin and dapagliflozin. These are considered to be the 4 pillars in the management of HFrEF. So I can write chronic HFrEF. So among the SGLT2 inhibitors, obviously DAPA and EMPA has been shown to be associated with improved survival, reduced heart failure hospitalization, and they are also going to delay the worsening of heart failure or delay the progression of heart failure. So right answer for this question is simple, straightforward, option A. Question number 20 is a repeat of 19th question, to be honest. The patient is having a chronic HFrEF because the patient's ejection fraction is low. They're asking which of the following treatment will delay the progression of cardiac disease. Among the 4 pillars, the only thing that's mentioned in the options is empagliflozin, which is a diabetic drug, to be honest, but still it has tremendous benefit in case of heart failure and reduced ejection fraction. So the right answer is simple, option B, empagliflozin. Moving to question number 21, which of the following is an adverse effect associated with long-term use of intermittent teriparatide for the treatment of osteoporosis? Teriparatide is basically recombinant PTH that is given by subcutaneous injections. In fact, it's a daily injection, and they're asking about the side effect of long-term use, right? So option A, osteonecrosis of jawbone. It's a side effect of bisphosphonate, not teriparatide. Subtrochanteric fracture or atypical femoral fracture, again, is a side effect of long-term use of bisphosphonate, not seen with teriparatide. And loss of bone mass is neither associated with bisphosphonate nor associated with teriparatide, because both of these drugs are going to increase the bone mass, right? Teriparatide is an anabolic agent. It's going to activate the osteoblast. And Bisphosphonates are osteoclast inhibitor. They're going to prevent the bone destruction. So what about osteosarcoma? Yes, that's the right answer for this question, because teriparatide in animal models, if used for long term, for more than 2 years, it can be associated with risk of osteosarcoma. That's the reason its approval is limited to only 2 years, not more than that. Coming to question number 22, which of the following is false regarding nutritional rickets? Rickets and osteomalacia are complicated forms of vitamin D deficiency where the patients will have hypophosphatemia, patients will have high alkaline phosphatase and high PTH, and this high PTH is basically secondary hyperparathyroidism as a response to hypocalcemia. But in most of the case of nutritional rickets, at the time of presentation, patients will have normal calcium thanks to high PTH levels. That tends to normalize the calcium. So the serum calcium will be the just normal range, or maybe in the low normal range. It's very classic of a nutritional rickets. What is wrong here is definitely urine calcium creatinine ratio of more than 0.15, which is seen in primary hyperparathyroidism and not secondary hyperparathyroidism, like vitamin deficiency. So the right answer for this question is going to be urine calcium creatinine ratio of more than 0.15. In fact, that increased urinary calcium creatinine ratio, that is hypercalciuria, is the important reason for renal stones in patients with primary hyperparathyroidism, but that's not seen in vitamin deficiency and rickets. In fact, the urine calcium creatinine ratio will be low in these patients. Coming to question number 23, which among the following drugs decrease serum parathyroid hormone levels? So option A, they are giving risedronate, which is a bisphosphonate. It's an osteoclast inhibitor. One of the important side effects of bisphosphonate is hypocalcemia, which can reflexly increase the PTH levels. So risedronate is associated with increased PTH and not suppressed PTH. What about lithium? Lithium is one of the common cause of unexplained hyperparathyroidism. So it's going to increase PTH and not decrease PTH. We know that diuretics, probably if they have given thiazide diuretics, they would have created a kind of ambiguity, because thiazide diuretics can cause hypercalcemia, which can reflexly reduce the PTH levels. But here they have just mentioned diuretics. It can be loop diuretics also, which is going to produce basically hypocalcemia, and that can actually increase the PTH levels by default. And what is the right answer for this question is calcitriol. So because calcitriol, by directly acting on vitamin D receptors in the parathyroid gland, it's actually going to reduce PTH levels. In fact, there is a synthetic drug called as paracalcitol, that is a kind of a vitamin D receptor agonist that is used in case of primary hyperparathyroidism to reduce the PTH. So it's a kind of a drug that's related to cinacalcet, but cinacalcet is a calcium sensitizer acting on calcium sensing receptor, but paracalcitol acts on vitamin D receptor. It's a VDR agonist. So that's going to reduce the PTH. So right answer is simple, straightforward option B, calcitriol. Coming to 24th question, a tall 10-year-old boy presents with sexual maturity rating of 5. At 10 years, the child is tall and SMR is 5, which means the child is suffering from precocious puberty. SMR of 5 usually will be achieved at around 14 or 16 years of age, but this child at 10 years itself is having SMR 5. Definitely it is precocious puberty, and hyperpigmentation possibly due to high ACTH, which clearly confirms that we are dealing with a case of congenital adrenal hyperplasia that causes hypertension and high adrenal androgen production. So we have discussed so many times that if the first number is 1, that's associated with salt retention, right? That's associated with salt retention and hypertension due to excessive 11 DOC. Other two, 21 beta hydroxylase and your SEC, side chain cleaving enzyme deficiency, is going to be associated with salt wasting only and not salt retention. And if the second number is 1, that will be associated with high adrenal androgen production also. There will be high DHAS and androstenedione. So this is the one that's going to be associated with precocious puberty in male children and virilization in female children at birth. So I'm going to go with option A, that is 11 beta hydroxylase deficiency, simple. Moving to question number 25, decreased sexual maturity and hypogonadism is seen with deficiency of which micronutrient? The answer is zinc for this question, because zinc deficiency is such a common deficiency according to WHO report, where it states 17% of children in developing countries and third world countries tend to have zinc deficiency. So zinc deficiency in children is associated with two important problems. One is growth retardation, and second is hypogonadism, especially in male children. In male children, hypogonadism, and because of that, you can have decreased and delayed sexual maturity. Apart from that, they can have low immunity and recurrent infections also, but these two are very, very important. So what about copper deficiency? Copper deficiency is a very important DD for B12 deficiency, because copper deficiency also produces anemia similar to B12 deficiency, like megaloblastic anemia. And copper deficiency also tend to produce peripheral neuropathy and subacute combined degeneration of the cord. So it's very, very important DD for B12 deficiency. And selenium deficiency typically tend to produce the classic Cashan disease and Cashenbeck disease. Cashan disease is cardiomyopathy, Cashenbeck disease osteoarthropathy. Iron deficiency typically tend to produce microcytic anemia. We know that. So the right answer for this question is simple, straightforward, zinc deficiency. Which gene defect causes familial type 2 hyperlipidemia? Hyperlipidemia means high LDL levels, and that is because of what? Type 2. in Fredrickson classification? It is due to mutations in the LDL receptor. It's a loss of function mutation. So if LDL receptors are not functioning in the liver, they will not be able to absorb LDL from the blood. So there will be high circulating LDL levels, resulting in high cardiovascular risk. And there are two forms, heterozygous and homozygous form. Heterozygous is more common, but homozygous is the most severe, because in homozygous form, the LDL levels can reach even 600, 700. That results in early cardiovascular death. And heterozygous forms, you won't have that much high LDL, maybe in the 200, 300 range, but still it is risky. And what about ApoE? ApoE mutations will result in familial dysbeta lipoproteinemia, that is type 3 in Fredrickson classification, which is going to have elevated ideal intermittent density lipoproteins, and that is also called as remnant disease. And what about ApoC2 deficiency? ApoC2 deficiency is going to result in familial chylomicronemia, which is basically type 1 in Fredrickson classification. So not only this, even LPL defect, lipoprotein lipase deficiency, also can produce the same problem, where the triglyceride levels will be too high in these cases. ApoB48 is just a dummy choice. There is no deficiency like that as of now. And coming to question number 27, a 30-year-old woman having lost a newborn is producing breast milk, which risks developing into a breast abscess due to milk stasis and incomplete emptying. Which drug can prevent this complication? Here we wanted to suppress the milk production in this lady so that there will be no risk of breast abscess. To suppress the milk production, we have to stop prolactin from coming out of the anteripituitary. For this purpose, we need to increase the dopamine levels or stimulate the D2 receptors in the anteripituitary, because dopamine is going to inhibit the prolactin release. For that, we need to give a dopamine receptor agonist like cabergoline or bromocriptine. We prefer cabergoline because it's long acting. Bromocriptine is a short acting drug, so it's better to give cabergoline in this case. So other choices are not correct. In fact, if you look at metoclopramide and chlorpromazine, they are basically D2 receptor blockers. So technically, they can actually increase the milk production. In fact, metoclopramide and domperidone to an extent is used as galactagogues or secretagogues of milk. So that's not the right choice. The right answer is option B for this question. What about question number 28? A patient presents with neck swelling compressing the trachea and esophagus. Histopathological assessment shows cell next with pink extracellular amyloid stroma. What is the cell of origin of this tumor? So I clearly mentioned amyloid stroma. When it comes to thyroid cancer and amyloid stroma, you have to always think about medullary thyroid cancer, because MTC is a cancer of parafollicular cells, C cells of the thyroid gland, and they secrete calcitonin, and that calcitonin is the main reason for the amyloid stroma that you see, and it can cause systemic amyloidosis also in some cases. The right answer for this question is going to be parafollicular C cells. Follicular cells are going to typically result in other tumors like PTC, that is papillary thyroid cancer, or probably even follicular thyroid cancer, or probably even anaplastic cancer, but definitely not MTC. MTC is unique. So that's why the tumor marker for PTC or FTC is going to be thyroglobulin, whereas the tumor marker for your MTC is going to be calcitonin. Coming to question number 29, what is the most common cause of proptosis in a middle-aged person? We have discussed so many times. In adults, the most common cause of unilateral as well as bilateral exophthalmos or proptosis is going to be Graves' disease. So it's going to be thyroid eye disease for sure. Soft tissue tumor in orbit is wrong. Optic nerve meningioma is typically seen in NF2, especially neurofibromatosis type 2, and cavernous hemangioma is the most common orbital tumor in adults. So that's not the most common cause of proptosis in adults. It's the most common orbital tumor in adults though. The right answer for this question is thyroid eye disease, typically a Graves' disease. Next, moving on to the next section on nephrology and hypertension. Moving to question number 30, they are asking about decrease in GFR is associated with which of the following. We have a concept of something called as net filtration rate, which is based on 2 to 3 things. One is the filtration coefficient Kf. Second is the renal blood flow. Of course, the renal blood flow increases, GFR will increase. Renal blood flow decreases, GFR will decrease. And filtration coefficient per se is based on capillary permeability as well as the capillary surface area and the glomerulus. Next, we have the net filtration pressure. NFP is based on 2 things, hydrostatic pressure and oncotic pressure on the capillary side as well as the Bowman's capsule side. So, if the hydrostatic pressure on the capillary side is increasing, NFP will increase and GFR will increase. And similarly, if the oncotic pressure on the Bowman's capsule side is increasing, that will also will increase the NFP and the GFR. On the other hand, if the oncotic pressure on the capillary side, glomerular capillary side is increasing, the NFP will decrease and the GFR will decrease. Or if the hydrostatic pressure in the Bowman's capsule increases, then again it's going to oppose the filtration. So they are asking about conditions that are associated with decrease in GFR. So technically, if the hydrostatic pressure of the capillaries or the oncotic pressure of the Bowman's capsule decreases, the filtration will decrease. Or alternatively, if the oncotic pressure in the glomerular capillary increases, or if the hydrostatic pressure in the Bowman's capsule increases, that's going to be associated with decrease in GFR as well. So what about option A? Option A, increase renal blood flow. That's basically going to increase the GFR, not decrease GFR. Increase glomerular hydrostatic pressure, simple, it's basically going to increase the filtration pressure in GFR. And decreased glomerular oncotic pressure is also going to increase the filtration pressure in GFR. We've discussed that already. But decreased Bowman's capsule oncotic pressure is going to actually reduce the NFP and reduce the GFR. So that's going to be the right answer, because increase in Bowman's capsule oncotic pressure is going to basically increase the filtration pressure in GFR. So right answer for this question is option C, simple and straightforward. What about 31st question? A 10-year-old child presented with follicular tonsillitis for which antibiotics was prescribed. In a few days, child developed flank pain and rash. Peripheral blood demonstrated eosinophilia and urinalysis showed WBC cause. What is the likely diagnosis? This is something that we discussed tons of times in many of our past lectures. So here, the patient has history of usage of some drug like antibiotic, typically a penicillin drug it will be, because it's a tonsillitis. And following that, they have developed rash, eosinophilia, and WBC cause in the urine, which is a classic presentation of allergic interstitial nephritis, or we can call it as allergic form of acute interstitial nephritis. If it's a pyelonephritis, the presentation will be different. They will have fever, they will have unilateral flank pain rather than bilateral flank pain, and there will be no such association with the use of antibiotics or any other drug. Burger disease is IgA nephropathy. It's a completely different disease altogether, and urinary tract infection is also something like pyelonephritis only. Patient would have had fever and the history would have been different. The right answer for this question is simple, straightforward option A, allergic interstitial nephritis. And you all know that this WBC cause that you see is associated with negative urine cultures because it's a sterile pyuria, right? Coming to question number 32. A 30-year-old man was admitted to the hospital after 3 days of abdominal pain and vomiting. His laboratory report showed a potassium value of 3.2, hypokalemia. All of the following can be seen except ventricular tachycardia. We know that one of the important problems in potassium imbalance is going to be ventricular arrhythmias, and that's one of the important reasons for death in these patients. That's the reason why we fear potassium imbalance, especially hypokalemia and hyperkalemia. And quadriparesis, yes, hypokalemia is one of the important DDs for Guillain-Barré syndrome also. So quadriparesis and muscle weakness is very common. In fact, it can present with areflexia just like GBS. Diabetes insipidus, yes, we have discussed so many times. There are two things that causes nephrogenic diabetes insipidus, electrolyte imbalances, that is hypercalcemia and hypokalemia. So diabetes insipidus, predominantly it's due to NDI, that is nephrogenic diabetes insipidus, which is basically due to ADH resistance in the kidneys. And to some extent, it's due to central diabetes insipidus also, because hypokalemia in animal models has shown to reduce the ADH output from the posterior pituitary as well. But the most important reason is ADH resistance, that is nephrogenic diabetes insipidus. And what is not seen is cerebral edema. Cerebral edema, in fact, is a complication of hyponatremia and not hypokalemia, right? So that's seen in your sodium changes, not in potassium changes. All right. Coming to question number 33, a 35-year-old male presents to the clinic with complaints of nausea, diarrhea, and vomiting. Upon further investigation, ABG analysis reveals pH of 7.55, PCO of 50, and bicarbonate of 44. Given these findings, which of the following is the most likely analysis? It's a straightforward one. pH is alkalotic, so definitely it must be some form of alkalosis only. And you can see the pH is increasing, but carbon dioxide is increasing and bicarbonate is also increasing. All arrows moving in the same direction means it's going to be metabolic only. So my diagnosis will be a simple, straightforward metabolic alkalosis. And of course, the high bicarbonate is the one that correlates with the alkalotic pH. High carbon dioxide, if it was the primary, it should have caused acidosis only and not alkalose. So this must be compensated response. So let us move on to the next question. A patient arrives at the emergency department presenting with symptoms of abdominal pain, vomiting, tachypnea, and tachycardia. Laboratory results are as follows. pH is 7.34, sodium 135, potassium 5, bicarbonate 12, chloride 92, random blood sugar is 450. Given these laboratory findings, which of the following statement best describes the patient's acid-base status? Just with the history, I can say this is a case of DK and it must be a high anion gap metabolic acidosis only. But if you want, you can calculate the anion gap. Anion gap is nothing but what? Sodium minus bicarbonate plus chloride. So here the sodium value is 135. In fact, in most DK patients, there will be a pseudo hyponatremia, false lowering of the sodium, which is also called as hyperosmolar hyponatremia. We know that. And once you correct the glucose, this sodium will improve. And bicarbonate is 12 and chloride is 92. So 135 minus 102. So we're going to get an anion gap of approximately around 32. Anything more than 12 is high anion gap. So this patient is having a high anion gap metabolic acidosis. As simple as that, it's a case of Hagma. Coming to question number 35, choose the incorrect statement regarding renal tubular acidosis. They're asking about type 2 and type 4 here. They have not given anything about type 1. So type 2, yes, it's very commonly associated with Fanconi syndrome. So because it's a proximal artery. So proximal nephron is the one that's important for solute absorption. So loss of solutes like amino aciduria, phosphaturia, and glycosuria is a classic triad of Fanconi syndrome that's very common in proximal artery. Bicarbonate urea, yes, of course. One of the important functions of proximal nephron again is bicarbonate reclamation, and if that is lost, you're going to result in bicarbonaturria, which is a classic feature of type 2 RTA. That's also correct. And RTA type 4 is also with the hypokalemia. That's wrong. We have discussed n number of times, even in our marathon sessions, we discussed that type 4 RTA is a hyperkalemic RTA, which is due to aldosterone deficiency or aldosterone resistance. That's the reason why option D is also correct. So the only incorrect statement here is RTA4 is associated with hypokalemia. So that's the right answer. So moving to question number 36, erythropoietin is secreted by which of the following? It's one of the most simplest questions in this INI. So 90% of erythropoietin, we know it's going to come from the kidneys only, and 10% is going to come from the liver. In the kidneys especially, it's going to come from the interstitial fibroblast-like cells that too near the proximal converted tubule. Okay. So that's the source of erythropoietin predominantly. The right answer for this question is option A and B together. There are no other known source of erythropoietin in humans. So question number 37. So you have to match the following. It's based on diuretic action. Osmotic diuretics have a diffuse mechanism of action throughout the nephron. It's going to act on the water permeable regions like proximal converted tubule and the descending limb of loop of Henle. That's the major site of action. Of course, the collecting duct also, but collecting duct alone is not the major site of action for osmotic diuretics. Thiazide diuretics. Thiazide diuretics typically act in the sodium chloride transport. They're also called as thiazide sensitive. Sodium chloride transport is in the distal converted tubule. So this is also wrong. Aldosterone antagonists typically act on the collecting ducts, in the principal cell of the collecting duct. So that's also wrong. It's not going to act on the distal converted tubules. And what about option B? That's the right answer for this question, because carbonic anhydrase inhibitors are going to act on proximal converted tubules. In fact, the carbonic anhydrase enzyme is concentrated on the brush border of the proximal converted tubule. So that's why that's the right choice. Next, let us move on to the rheumatology section. So question number 38, which of the following in IgA vasculitis? Typically, we are talking about enoxaparin purpura warrants corticosteroid use. So arthritis, abdominal pain, skin rash, all of these things can be managed simply by giving NSAIDs or by supportive management. That's it, nothing more is required. But if the patient is having complications like GI bleeding or probably some organ involvement like severe renal failure, in those cases, definitely we have to start with corticosteroids. But in general, enoxaparin purpura and IgA vasculitis is going to be self-limiting in nature, and most of the times in children and adolescents, we just give supportive care, or maybe some practitioners use low-dose steroids even though it is not indicated, but generally it's supportive care only, unless until there is some major organ involvement like GI bleeding or probably renal failure. Otherwise, we don't use steroids and immunosuppressive therapy. The right answer for this question is option D, GI bleeding. Coming to question number 39, all of the following statements regarding ankylosing spondylitis are true except ankylosing spondylitis typically tend to occur in the early 20s, true statement, rare after age 40, very, very true. So that's a correct statement, not the right answer though, because they are asking what is incorrect. And more common in males than in females, absolutely correct. It's going to occur in young males. HLA-B27 is positive in more than 90 to 95% cases. Again, it is correct. In fact, it's one of the diseases that has the maximum HLA-B27 association. And MRI shows non-erosive joint widening. This is absolutely wrong. In MRI, you're going to see joint narrowing, plus at the same time, in vertebral column, you're going to see lots and lots of erosions. There's a disease that's going to produce erosive arthropathy. So option D is wrong. Okay, so that's straightforward. That's the right answer for this question. What about question number 40? Identify the crystal in a patient with a urinary pH of 8.7. Remember, the normal urinary pH is going to be 4.4 to 6.5. So that's the typical urine pH, which is acidic, of course, because of the excretion of acids by the distal nephron. And here the pH is 8.7, which means it's alkaline pH. Whenever the urinary pH is alkaline, it promotes the formation of two crystals and two stones. That is struvite, triple ammonium phosphate, and second one is going to be the calcium phosphate. And they have given the crystal image also, which is typically coffin lid, right? It's typical coffin lid crystals, which is nothing but triple ammonium phosphate or magnesium ammonium phosphate or struvite crystals. It's invariably also with some infections, especially urease positive infections like Klebsiella proteus or even ureaplasma ureolytica. So calcium oxalate, cysteine, uric acid, all of these crystals tend to form in acidic urine and not in alkaline urine. And they have different shapes as well. We're not going to discuss about that right now. Which of the following is not a criterion for the diagnosis of Kawasaki disease? Yes, the rash is very common in Kawasaki. Lymphadenopathy is very common. Strawberry tongue is very common. What is not common is purulent conjunctivitis. What you see is non-purulent sterile form of conjunctivitis in Kawasaki. You do have conjunctivitis. It's a pink conjunctivitis. It's a non-sterile form. You don't have pus. Even if you take culture, it's going to be negative only. It's a sterile, non-purulent form. Right answer for this question is again simple, straightforward option A. And the treatment of choice for Kawasaki disease is going to be IVIG plus or minus aspirin. That's it. Coming to neurological questions, here's your first one. We have discussed tons and tons of times. Which of the following is seen in human weakness? The characteristic feature of human weakness is hyperreflexia, that is brisk deep tendon reflexes, and Babinski posterior, that is nothing but extensor plantar response. The right answer for this question is hyperreflexia. That is exaggerated deep tendon reflex. Atrophy is a feature of element. Fasciculation is a feature of anti-Honsel damage in element. Rigidity is a feature of extrapyramidal problems and not pyramidal weakness like Yeoman palsy. Coming to question number 43, identify the stage of sleep based on EEG shown below. So by looking at the EEG itself, you can easily guess that it mimics an awake pattern. So awake pattern and sleep means it must be REM sleep only. And in EMG, you can see that the muscles are paralyzed, which is again a characteristic feature of REM sleep. Only diaphragm and your extraocular muscles will be spared and they won't be paralyzed. Apart from that, all the muscles will be paralyzed. And electrooculography is going to show rapid eye movements. You can see gross fluctuations here indicating eye movements. So it clearly tells that we are dealing with a REM sleep. Right answer is option D. Let us move on to the next question. Which of the following is not indicative of an underlying serious pathology in headache? This is a table from Harrison. They clearly mentioned that sudden onset headache, risk factor for severe headache, worst headache ever. It can suggest a berry-aneurysm rupture. Vomiting that precedes headache can indicate a raised ICP. Subacute worsening over days or weeks also can tell you it could be probably due to raised intracranial pressure, especially a tumor. Pain induced by bending, lifting, coughing, again indicative of raised ICP. Pain that disturbs sleep or presence immediately upon awakening. Known systemic illness. Onset after age 50 or 55. So any elderly new onset headache is very, very dangerous. Fever or unexplained systemic signs. Abnormal neurological examination again can indicate some stroke or space occupying lesion. Pain associated with local tenderness like region of temporal artery indicating a giant cell arteries. Again, it's a dangerous headache. So age more than 50 definitely suggests you have some dangerous problem. Temporal tenderness likely to be GCA, dangerous. Subacute progression over 4 weeks, again dangerous, indicating a raised ICP or a space occupying lesion. The only thing that we can eliminate here is chronic cocaine use. They have mentioned chronic, so that's a point. It's not subacute. And yes, cocaine use sometimes if they present with sudden onset headache, still you have to consider the possibility of intracranial hemorrhage, but they have mentioned about chronic cocaine use probably, so that's not going to be the right answer. Okay, I mean that's only the right choice, so that's the right answer in this case. It's incorrect. Going to question number 45, interventional technique used for the management of cerebral aneurysms. I told you for management of berry aneurysms in the brain, there are two important options. One is going to be clip and second is coil. That is clip versus coil strategy. Clipping is a craniotomy based procedure. You have to cut open the skull, you have to locate the aneurysm and clip it. And that's also called as aneurysmal clipping. And coiling is an endovascular procedure. It has a lower mobility and motility. That's why if the aneurysm is amenable to coiling, it's always better to go for coiling. The right answer for this question is endovascular coiling. Embolization, we don't attempt for berry aneurysms. Basal stent placement as a standalone procedure is not going to be effective. Stent placement can be utilized to coil the aneurysm subsequently, but as a standalone procedure, that's not going to be effective. Blunt angioplasty is going to worsen the problem because you can't do angioplasty for an aneurysm, right? So technically, we are going to go for coiling. That's the right answer for this question. What about 46th question? A 40-year-old patient presents with left facial weakness. Routine lab workup was normal. What is the next best step in management? Here they are talking about a condition called as Bell's palsy, which is an idiopathic element type of facial nerve palsy. In fact, the most common cause of unilateral element type of facial palsy is Bell's palsy, which is a diagnosis of exclusion. It's an idiopathic condition. So all patients will receive corticosteroids. That's the best therapy that you can use. In some patients, we use acyclovir, even though a lot of studies have said that acyclovir addition or valcyclovir addition is not going to improve the overall outcome. So it should be avoided. But in modern practice, according to the severity of Bell's palsy, we can probably add acyclovir maybe as an optional therapy. For example, we use a severity grading system called as House-Brackman grading. House-Brackman grading. In that, grade 4 or grade 5, if it is present, probably you can add antivirals like acyclovir or valcyclovir. I typically prefer valcyclovir 1 gram TDS for 7 days. Or if you want, you can use acyclovir 400 milligram 5 times a day for 7 to 10 days also. But valcyclovir has a superior bioavailability and superior efficacy and lower side effects. That's why I prefer valcyclovir. But anyways, it's only a plus or minus. Only in severe facial palsies, you can use antivirals. But apart from that, all patients will receive steroids if you use within 72 hours. Especially if you're going to use within 7 hours, within 3 days, or at least within 7 days, the outcome is going to be very, very good. If you use within 72 hours, 90% of the patients will have complete recovery. That's why this is the most important treatment in Bell's palsy. Antibiotics and physiotherapy are just like dummy choice. Physiotherapy we do like patching of the eyes and patching of the facial skin and all, but that's not the standalone therapy. So corticosteroids are the most important, as simple as that. Coming to 47th question, which of the following clinical features are seen in Korsakoff psychosis? Remember, Korsakoff is a chronic form of thiamine deficiency and it is virtually untreatable. It cannot be reversed even with thiamine treatment. But acute form of thiamine deficiency will result in Wernicke's encephalopathy, and that is treatable with thiamine. That's reversible with thiamine. So what are the features of Wernicke's? Ophthalmoplegia, ataxia, and confusion that can be reversed with thiamine. So you don't see ophthalmoplegia and Korsakoff, whereas the classic features of Korsakoff will be amnesia and confabulation. Amnesia can be retrograde or antegrade, but the long-term memory will be intact though. So peripheral neuropathy will be seen in any chronic alcoholic. So that is because of axonal form of peripheral neuropathy due to axonal damage. So that's fine. So 1, 2, and 4 will be seen in Korsakoff patients, but acute problems like ophthalmoplegia will not be seen in Korsakoff. So right answer for this question is going to be option A. 1, 2, and 4 are the features of Korsakoff. So what about 48th question? All of the following are functions of superior oblique except. Remember, superior oblique is supplied by the trochlear nerve, fourth cranial nerve. And the functions of superior oblique can be remembered in the form of a mnemonic called SOLID. We have discussed so many times. L for lateral movement, that is abduction. I for intorsion. D for depression. Intorsion is the primary function of superior oblique though. So abduction is fine, depression is fine, intorsion is fine, but not adduction. Adduction is not a feature of superior oblique. So what about 49th question? Third cranial palsy, which of the following is not affected? Remember, except the lateral rectus that produces abduction and your superior oblique, the functions we have discussed already, all other muscles are supplied by the third cranial only. So you are going to have problems of elevation because of involvement of superior rectus, which is supplied by third nerve. You are going to have problems of adduction because medial rectus is also supplied by third cranial only, and levator palpebrae superior is also supplied by third cranial. So ptosis is a very common feature of third nerve palsy. So what you won't see in third nerve palsy is abduction, which is basically a function of lateral rectus that is supplied by sixth cranial nerve. We know that, right? So right answer for this question is abduction, lateral movement. Coming to 50th question, cannabinoids are approved in all of the following except. So again, I've quoted Harrison as a reference. Remember, in 3 epileptic syndromes, cannabinoids are FDA recommended as an add-on. One is Dravet syndrome, second is Lennox-Gastaut syndrome, third is tuberous sclerosis. So where you don't use cannabinoids is going to be Rett syndrome, where another new drug has been approved recently. We're not going to talk about that right now. So next, moving on to the pulmonary medicine critical care section. Question number 51, inhaled nitric oxide is used in, I told you inhaled nitric oxide is a emergency treatment for patients who are having high pulmonary artery pressures. If you want to reduce the pulmonary artery pressures or if you want to reduce the RV afterload, you can go for inhaled nitric oxide. Clinically, there are 3 to 4 classic situations where you use. One, in patients with acute pulmonary embolism to reduce the pulmonary pressures. And number 2, in patients with pulmonary artery hypertension, which can be a primary pulmonary artery hypertension or it could be associated pulmonary artery hypertension. Even in vasoreactivity testing, we are going to use inhaled nitric oxide only. Third, you can use in patients with STEMI, especially in inferior STEMI, with acute right ventricular failure. If there is an RVMI, to reduce the RV afterload, you can use inhaled nitric oxide. And last but not the least, you can use in patients with refractory ARDS as well as a bridging therapy till transplant. So these are the usual areas where you use inhaled nitric oxide. So here, the answer is simple and straightforward, primary pulmonary artery hypertension. In other 3 situations, there is no point in using inhaled nitric oxide. Coming to 52nd question, a 40-year-old male presented to OPD with complaints of excessive daytime sleepiness, and his wife also complains that he snores a lot in the night during sleep, which means it's likely to be a case of obstructive sleep apnea. Which of the following is incorrect regarding his condition? So option B, fall of oxygen saturation triggers waking episodes at night. That's correct. So because of obstruction and apnea, there will be fall in oxygen saturation. That is because of increase in carbon dioxide. That is basically going to trigger the waking episodes in the night. So these patients won't sleep properly in the night. That's why they have excessive daytime sleepiness. Option C, episodes of apnea increases stress on the heart. That's correct. Remember here the apnea is due to obstruction, right? So because of the obstruction, patient will put more inspiratory effort and that's going to increase the intrathoracic pressure, which is going to alter the preload and afterload on the heart. So that definitely puts stress on the heart, and long-term cardiac remodeling and cardiomyopathy is also common in these patients. And hypoxemia is going to stimulate respiratory effort, correct? In fact, that is the one that promotes the waking episodes as well as it's going to stimulate respiratory effort because hypoxemia is due to high CO2. We know that CO2 is a strong trigger for respiratory effort, and that's the reason why this is going to basically increase or stimulate the respiratory effort. What is wrong here is increased tone of pharyngeal muscle that's going to worsen obstruction. That's wrong. In fact, reduced tone or flaccidity of the muscles of the pharynx is the one that's going to result in fallback of the tongue, resulting in obstruction at the level of the pharynx, right, upper airway. So that is the right answer for this question because it's a wrong statement. It's not increased tone, it's decreased tone. Coming to 53rd question, a 30-year-old patient presents with fever and cough. Along with that, he's also having a tenacious white sputum. Which of the following should be used for treatment? Remember, dextromethorphan and codeine are basically antitussives, especially in a patient with productive cough. 100% we don't use. Bromhexin is a kind of a mucolytic drug along with N-acetylcysteine, but we can't use a combination of dextromethorphan and bromhexin because that Doesn't make any sense. It's an illogical combination. So you wanted to suppress the cough, plus at the same time you want to give a mucolytic order. That doesn't make any sense. So in a patient with thick, tenacious white sputum, especially a productive cough, it's better that you give only a mucolytic drug like bromhexin. So dextromethorphan again doesn't make any sense because it's an antitussive, it only suppress the cough. So what about the thick sputum? That's going to accumulate in the lungs. So that's going to cause problems like infection later on. So it's better to go only for syrup bromhexin. Right answer is option D. Coming to question number 54, a 60-year-old male underwent surgery with rocuronium as a muscle relaxant and has not regained muscle function post-surgery. Which of the following can result in fastest reversal? Remember, sugammadex, this is something that we have discussed in critical care section in respiratory failure. So where I've told that sugammadex is something that can be used for vecuronium and rocuronium. So reversal of vecuronium and rocuronium. Some of the fastest reversal agents for these drugs. And neostigmine can be used for a non-depolarizing neuromuscular blockers. Used as a reversal agent for non-depolarizing neuromuscular blocking agents. Heterophonium is used for diagnosing myasthenia gravis. Not here. Atropine doesn't have anything to do with neuromuscular reversal here because atropine doesn't even have any effect on the nicotinic receptors. It is a anticholinergic, anti-muscarinic drug, right? So there is a new drug that's called as calabadion. Calabadion, it's a broad spectrum drug. It can be used for reversal for all neuromuscular blocking agents. In the future, this can also be asked, so please make a note of it. So right answer for this question though is going to be sugammadex because they are specifically asking about rocuronium. Here is your 55th question. Which of the following drugs are used in the treatment of cyanide poisoning? The best treatment for cyanide poisoning will be IV hydroxycobalamin, B12, but that's not given in the option, so we can explore the alternatives. Nitrates can be used because they work by the mechanism of converting hemoglobin to methemoglobin. I'm going to talk about the exact mechanism, that's the mechanism how nitrates work. And sodium thiosulfate also can be used as an alternative, but definitely not glyceryl trinitrate. Sodium thiosulfate works by converting cyanide to thiocyanate, so that can be extracted in the urine, but definitely not glyceryl trinitrate because NTG, glyceryl trinitrate or nitroglycerin, is used in angina, nitrate. So nitrates can be used, but not nitrates. So 1, 2, and 3 can be used. So right answer is option C. 56th question. Which of the following is our criteria for anaphylaxis? Every single criteria for anaphylaxis will include hypotension and low BP and not hypertension. So that can be excluded. So it's a question that has multiple right answers. So yes, urticaria swollen classic, respiratory distress like stridor, wheeze, classic. And patients are going to have persistent abdominal cramps and vomiting. Even that is a classic. Here is the criteria for anaphylaxis that I have taken from Harrison. So you can go through that later on. So everything will have hypotension in it and not hypertension. Next section, gastroenterology and hepatology. We have a few questions in this as well. 57th question, a 55-year-old male with history of chronic alcoholism present to emergency department with vomiting, altered sensorium. So whenever you see a chronic alcoholic with altered sensorium in the emergency, the first TD you make is wernicke's encephalopathy. As simple as that. And he's also having hypotension. Last binge drinking episode was 7 days ago. Ultrasound reveals a small liver with coarse echotexture and mild portal dilatation. Yes, this indicates cirrhosis, but they're not given any gross signs of decompensated liver disease like jaundice or probably ascites or severe splenomegaly. They're not given anything like that, right? So I'm not going to really think about hepatic encephalopathy as the first TD here, even though it's one of the differentials, but that's not the first TD. The first TD is wernicke's. Given these findings, what is the most appropriate next step in managing this patient? Administer lactose and wait for stool passage is absolutely wrong because what are you going to do for this altered sensorium? And how can you ignore wernicke's in this patient with chronic alcoholism? So I cannot do that. So that's a wrong choice. Perform endoscopy to assess for varices. Yes, this could be the reason for hypotension, but still it can be done later after stabilization. Need not be done immediately in the emergency. Administer chlordiazepoxide is also wrong because this patient had a last binge 7 days ago. So typically I'm not talking about withdrawal state here or delirium tremens here, and that too in a patient with a probable liver failure and cirrhosis. I'm not going to consider chlordiazepoxide, which is a long-acting drug. So technically, it's better to give lorazepam for his altered sensorium, which is a short-acting drug, very good drug in patients with cirrhosis. Or you can use even other drugs like oxazepam also, but it's better to give IV lorazepam here. And most important treatment here is going to be thiamine because my first differential in a patient with chronic alcoholism and altered sensorium is wernicke's. There is no doubt about this. The right answer is likely to be option C in this case. Coming to 58th question, which of the following are the complications of GRD? Here they have given the extra esophageal complications of GRD. Patients can have asthma, patients can have laryngitis, patients can have pulmonary fibrosis. In fact, severe GRD is one of the important risk factors for ILD in cases of diffuse scleroderma. We have discussed that so many times. And chronic cough is also one of the classic manifestation of GRD. So everything can happen in GRD. So the right answer for this question is option D, 1, 2, 3, 4. Coming to 59th question, a 45-year-old patient presents regurgitation of food and weight loss. Over the past several months, a barium swallow is performed. What is the likely diagnosis? And the barium swallow shows a classic bird's beak appearance. So I'm going to go for achalasia cardia. But in case if the patient is 50 plus or 60 plus, I will be thinking about lower esophageal cancer or probably even a GE junction cancer, because lower esophageal cancers can produce a characteristic picture very similar to achalasia. That's why it's also called as pseudo achalasia. I don't know what's the exact question, but if the age is correct and the symptoms are correct, probably I'll be thinking about achalasia cardia only. Xenchus diverticulum also occurs in very old age patients where they will not have weight loss, but basically they are going to have that halitosis and regurgitation, and you don't get this classic bird's beak appearance in barium. You will see a different appearance. Diffuse esophageal spasm will present with chest pain predominantly in younger patients, and that's going to have a corkscrew appearance in barium swallow. So the right answer for this question is going to be achalasia cardia. So going to hemato-oncology section. So first one, pretty much simple and straightforward. Match the blood product with the shelf life mentioned in the next column. So single donor platelet, so typically has a shelf life of 5 days. And PRBCs is going to typically have a shelf life of 42 days maximum, depending on the preservative that you're going to use. And cryoprecipitate is going to have a shelf life of 1 year. FFP and cryoprecipitate 1 year always. Leukocytes, granulocyte concentrate, approximately around 24 hours. So A3, B1, C4 and D2. That's correct. So right answer for this question is option A. So coming to 61st question, which of the following is used in the treatment of hemophilia B? Remember, hemophilia B is due to factor 9 deficiency, not factor 8 deficiency. Of course, I cannot use factor 8 concentrates. Cryoprecipitate is something that's enriched for factor 8 only, so I cannot use. So what cryoprecipitate contains? It contains factor 8, it contains 1 Lebrun factor, and it contains fibrinogen predominantly. So these are the things that are high in cryoprecipitate. So anyway, it's not going to work for hemophilia B. FFP can work. Sometimes it's a poor man's alternative because it contains all the clotting factors in certain proportion. So FFP fine, that can be given. And cryo poor plasma is nothing but FFP minus cryoprecipitate. If you remove the cryoprecipitate from FFP, so you get cryo poor plasma. So even if you remove factor 8, 1 Lebrun factor and fibrinogen from FFP, still it will contain a lot of factor 9. So still it can be used for hemophilia B. It's one of the important alternatives for factor 9 concentrates in patients with hemophilia B. So if it's a multiple correct answer kind of a question, then it will be option A and D, both will be correct. Moving to 62nd question, a patient with unknown blood group experiences trauma and is unstable, requiring an urgent blood transfusion. Which types of blood should be transfused? It's a multiple right answer type of a question. So remember, the universal donor is O blood group. The best is going to be O negative, but still you can use O positive. The reason we know O blood group patients will have both antigens. Because of that, they don't have anti-A as well as anti-B. So because they don't have antibodies, they become universal donor. So O blood group can be used. The best is O negative only. But in urgent situations, if O negative is not available, you can go for O positive also. Right answer for this question is option C and option D both. Coming to 63rd question, which of the following is not a feature of GC-SP deficiency? We know GC-SP deficiency is inherited in X-linked recessive fashion, and it's the most common enzyme deficiency in the world. So it's going to affect predominantly males. So the first one is the right answer for this question because it's a wrong statement. Males and females are not equally affected. So males are affected predominantly. And it's due to deficiency of NADPH, which creates an oxidative stress that's going to lead to intravascular hemolysis, which is usually precipitated by certain triggers like drugs. We know that, and it's characterized by the presence of Heinz bodies in vital stains like new methylene blue. And in Romanowski right GM sustains, you're going to see that characteristic bite cells or blister cells. Coming to 64th question, which of the following is all true about Hodgkin lymphoma? I think they're asking about classic Hodgkin lymphoma. In the classic Hodgkin lymphoma, nodular sclerosis is the most common histological type in the world, and it's going to involve the mediastinum. Involvement of Valdez ring and mesenteric nodes is very unlikely in classic Hodgkin lymphoma, and it will be typically seen in non-Hodgkin lymphoma. So this is the right answer for this question because it's a wrong statement. CD15-30 positivity in RS cells is classic. So in fact, that's the very reason why we use a drug called brentuximab vedotin, which is an antibody drug conjugate against CD30, targeting these malignant Reed-Steinberg cells in case of refractory classic Hodgkin lymphoma. And Reed-Steinberg cells are derived from B cells. Yes, that's correct. In fact, the exact statement will be from crippled B cells in the node. That's correct. But anyways, the source of RS cells is B cells, right? So it's a basically kind of a B cell tumor only. So right answer for this question is option B. Valdez ring is commonly involved. That is not correct because it's a classic feature of non-Hodgkin, not a Hodgkin lymphoma. Coming to 65th question, which of the following presents with repeated catalase positive infections? Here the clue is straightforward. Catalase positive infection means in exam you have to always diagnose only chronic granulomatosis. What's the problem here? Here the problem will be defective NADPH oxidase complex. There are a lot of genes that are important in the formation of NADPH oxidase complex, but the most common gene that is mutated will be CYBB gene, and most of these gene defects are inherited in a X-linked recessive fashion. And because of defective NADPH oxidase, they will not be able to produce that respiratory burst or oxidative burst, and that's going to typically result in killing defect. So they can phagocytose, but they cannot kill the organism. That can result in persistent and repeated infections, which can lead to chronic pus formation, abscess, and even they can get converted to granulomas. These granulomas can cause obstructive symptoms of the gastrointestinal tract as well as in the urinary tract, which is why it is called as chronic granulomatous disease. And what are those catalase positive organisms? We can remember by a mnemonic called as space bat. There are a lot of mnemonics, but I use a mnemonic called space bat. So where S stands for Staphylococcus aureus, P stands for Pseudomonas aeruginosa, A stands for Aspergillus and probably even Actinomyces israeli, and C stands for Corynebacterium and Candida fungal infections as well, and E stands for Enterobacteriaceae species like E. coli, and B stands for Burkholderia complex, and A stands for again Actinomyces israeli, T stands for tuberculosis, Mycobacterium tuberculosis. And if you want to remember other organisms, you can remember Nocardia, maybe you can remember Listeria also. There are a lot of other organisms you can remember. Okay, so these are catalase positive organisms typically. So they can have repeated fungal as well as bacterial infections. What about X-linked A gamma globulinemia? So it's also a disorder that's inherited in X-linked recessive fashion. So typically it's going to affect males, and it's a problem due to defective Bruton tyrosine kinase gene. So these patients will virtually have no B cells, very low or even absent B cells, so they won't have any immunoglobulin. There will be near complete loss of all the immunoglobulins, including IgA, IgM, as well as IgG. So patients are prone for repeated bacterial infections that start manifesting after 4 months. Fungal infections is not a feature, but bacterial infections very, very common. After 4 months, up to 3-4 months, the maternal antibodies in the infant's blood will protect them, but after 4 months, they will start experiencing problems. That's typical. And severe combined immunodeficiency, typically due to ADA deficiency, but it can be due to RAG1-2 deficiency, or it can be due to interleukin-2 receptor gamma deficiency. But nevertheless, it's a problem of both T cells as well as B cells, and it manifests soon after birth. You do not wait for 3 or 4 months like your X-linked A gamma globulinemia. Just in like few weeks, your problems will start, and the patient will start getting life-threatening bacterial as well as fungal infections because of near complete loss of B cells as well as T cells here. It's a combined defect. That's why it's called SCID, severe combined immunodeficiency. Chidiac-Higashi syndrome is due to List gene defect, and it's going to present the form of a classic triad where the patient will have oculocutaneous albinism. It's a very, very important feature in exam to note for. Second, they will have repeated infections because of neutrophil function defect here. It's a lysosomal defect, like so. It's a function defect, so they'll get repeated infections. And you can also note something called as giant azurophilic granules within the neutrophils. That's so characteristic of Chidiac-Higashi syndrome. And third, patients will have platelet function defect as well. Platelet function defect, where the problem will be granule release, so they can have bleeding also. So these are the features of Chidiac-Higashi syndrome. So right answer for this question is option B, chronic granulomatous disease, which can be diagnosed with the help of something called as NBT test or the modern dihydrorhodamine test, which is a flow cytometry based test. Coming to 66th question, fish can detect all except, of course, point mutation, because point mutation can be tested by molecular methods like PCR. You know that point mutation is a molecular abnormality. It's not a chromosomal abnormality. Amplification, deletion, translocation are all chromosomal abnormalities that can be detected by fluorescent in situ hybridization. But point mutation is a molecular abnormality that can be detected by molecular studies like PCR only, not by fish. So the right answer for this question is simple, straightforward, option D. Coming to 67th question, all of the following are growth promoting proto-oncogenes except. Again, we have discussed extensively in oncology section. So fibroblast growth factor, platelet derived growth factor, transforming growth factor alpha, all are oncogenic proteins. TGF-beta is one of the classic example of tumor suppressor protein. The TGF-beta SMAD complex is basically a tumor suppressor complex. So that is not going to promote growth. In fact, loss of function mutation of this TGF-beta and SMAD complex is the one that's going to result in cancers, right? So right answer for this question is option D. Coming to 68th question, regarding ABO blood grouping, which statement is false? IgM is the most common antibody in ABO. That's correct. That's the reason these ABO antibodies cannot cross placenta. ABO antibodies are natural and present since birth. The term natural is correct, but present since birth is wrong because it is formed by a process, something called molecular mimicry, after getting exposed to the gut commensals. So this is a wrong statement. Usually the antibodies will be generated by around 3 to 4 months or maybe 3 to 6 months of age, not immediately after birth. ABO antigens are carbohydrates. Yes, they are oligosaccharides. We have discussed so many times. Antibodies are present only if antigens are absent. So that's also right statement. That's the basis of your O, AB, and all those blood groups and their associated antigens and antibodies. So the right answer for this question will be option B, which is an incorrect statement. Coming to 69th question, false regarding folate deficiency. Of course, one of the classic features of folate deficiency is high homocysteine but normal methylmalonic acid. The methylmalonic acid is also high. You can confirm it's a B12 deficiency. Right. If given at the diagnosis of pregnancy, can prevent neural tube defects. This is a wrong statement because neural tube defects can be prevented only if you give a preconceptional folic acid. Giving folic acid at the time of diagnosis of pregnancy cannot prevent the neural tube defects. If you give a preconceptional folic acid along with folic acid during pregnancy, you can reduce the risk of neural tube defects by approximately 60 to 70%, 60 to 70%, not completely though, 60 to 70% risk of neural tube defects can be reduced if you give a preconception and a supplementary folic acid during pregnancy, right? So option C, folate supplementation is required in children with chronic hemolytic anemia. That's correct because in any chronic hemolytic states, your RBC turnover will be high, so that demands more folate supplement. And folate stores in the body is also very low. It lasts only for 3 to 4 months. So you need to give supplemental folate in this condition. Vitamin B12 deficiency should be corrected before supplementing folate. This is actually a true statement because in many patients folate deficiency and megaloblastic anemia, you will have vitamin B12 deficiency also. If you don't test and treat for vitamin B12 deficiency and if you give only folate, there is a risk of worsening neurological manifestations, right? Hematological parameters will improve, but neurological manifestations will worsen because of B12 deficiency. So this is actually a correct statement. So what is incorrect among the four is the option B, definitely given at diagnosis of pregnancy, has nothing to do with neural tube defects. You have to be giving preconceptional supplemental folate. Okay, so right answer is option B, simple. Coming to question number 70, a patient undergoes PRBC transfusion. Which of the following is incorrect with regards to delayed hemolytic transfusion reaction, which is something that's going to happen after 24 hours. We have discussed so many times in our lectures that delayed means after 24 hours. So that's the reason why this is the right answer, because it's a wrong statement, because cola colored urine is going to occur after 24 hours, not after 2 hours, because it's a delayed reaction. And this cola colored urine is because of intravascular hemolysis. That's a classic feature of any hemolytic transfusion reaction, right? Failure of hemoglobin to rise is a correct statement. Increased indirect bilirubin is a correct statement because it's hemolysis, and increased serum LDH and even direct Coombs test will be positive in these cases. So right answer for this question is option A, simple. Coming to question number 71, and we are entering the infectious disease domain. Which of the following drugs used in the treatment of leprosy can result in hyperpigmentation? Easy one, it is like clofazimine. We have discussed so many times. Rifampicin can cause orangish discoloration of urine, but clofazimine is a leprosy drug that's going to be associated with hyperpigmentation and discoloration of the skin, and even the sweat will be colored so that even the cloths can get stained. So clofazimine is the answer for this. Coming to 72nd question, which of the following is not a polysaccharide vaccine? So there is a mnemonic for that, that's called as SHINT. So there are only 4 polysaccharide vaccines in practice. One is your Streptococcus pneumonia, that's a pneumococcal vaccine. Second is going to be Haemophilus influenza. Third is going to be for Neisseria meningitidis, meningococcal vaccine. And fourth one is going to be the typhoid vaccine, Salmonella typhi. So the right answer for this is hepatitis B vaccine, because it's not a polysaccharide vaccine, rather it's a subunit vaccine containing surface antigen. Coming to 73rd question, best investigation for malarial species identification. Easy one, it's thin smear with GMSA. Because in thin smear, you're going to have only one layer of RBCs, and with GMSA, the morphology is going to be seen very nicely. So that's the reason it's best for species identification. Thick smear contains multiple layer of RBCs, and the RBCs will be deformed also. So you can identify whether malaria is there or not, whether plasmodium is there or not, but it's not very good for species identification. That's why that's not the right answer. It's for screening. It's a very good screening test, but it's not going to tell you what species. Thin smear with acrid orange. So it's kind of a trap in exam. So acrid orange is a stain that's going to stain only the nucleic acid. So the plasmodium that contains the nucleic acid will stand out, but the RBCs that don't contain nucleus will not stand out in the background. So again, the morphology will not be seen very clearly here. So that's the reason you will not be able to say what species it is, but it's a kind of a screening test again. Okay, this technique is also called as Kawamoto technique. I don't know how many of you have heard of that. Then we have something called Buffy code. Again, it's a kind of a modified acrid orange based testing only, where you're going to use a capillary tube instead of a slide. That's it. So you'll mix with acrid orange and you're going to visualize the capillary tube especially the area under the Buffy coat directly under the microscope after putting a immersion oil. So that's again a kind of a screening test that's going to tell you whether Plasmodium is there or not, malaria is there or not. It's a screening test rather than being a species identification test. So the right answer for this question is simple, straightforward, option C. Coming to 74th question, a patient presents with fever for 5 days and retroabdominal pain suggestive of dengue fever. Which of the investigation should be conducted next for confirmation? According to the national dengue guidelines, for the first 4 days, day 1 to day 4, you can use NS1 antigen, but from day 5 onwards, you have to use IgM ELISA. So right answer for this question is option D. We have two miscellaneous questions. Of course, 75th question can be placed under reproductive endocrinology also. Anyways, 16-year-old girl present with primary amenorrhea. On examination, she has well-developed secondary sexual characters and labs revealed a normal LHN, normal FSH. Karyotype is 46XX. What is the likely diagnosis? So androgen insensitivity is ruled out because androgen insensitivity karyotype will be 46XY. It's not XX, so that's ruled out. Hormonal dysgenesis patients will have a high FSH and high LH, and they won't have secondary sexual characters, so ruled out. Kallmann syndrome, again, it's isolated GnRH deficiency. So going to have low LH and low FSH along with absent secondary sexual characters and anosmia, of course. So that's also ruled out. The only thing that's left is malignant agenesis. That's the right answer for this question, which is also called as MRKH or Mayer-Rokitansky-Kuster-Hauser syndrome. Last question. In contrast to ulcerative colitis, which of the following statements regarding Crohn's disease is true? So you're asking about what is true with regards to Crohn's disease. There is no increased risk of colon cancer is wrong because in modern studies, especially in Crohn's disease patients, those who have colonic involvement, the risk of colon cancer is comparable with that of ulcerative colitis. So that's a wrong statement. Continuous involvement rather than skip lesions is wrong because skip lesions is characteristic of Crohn's disease. Continuous involvement is seen in ulcerative colitis. Seldom manifest hematochezia is also wrong because if the patient is having a primary colonic Crohn's disease, they can manifest with hematochezia. In fact, even a regular hematochezia, even that statement is wrong. So what is the most important thing that separates Crohn's from ulcerative colitis is this fistulas and abscess, because fistulas are primarily due to transmural involvement, right? Unless until there is a transmural involvement, you don't get fistulas. That's the reason fistulas are so specific for Crohn's. It's usually not seen in ulcerative colitis. So right answer for this question is going to be option C. Perianal fistulas are frequent and very, very common in Crohn's disease compared to ulcerative colitis. And that completes our quick and rapid discussion of all the 76 questions that was asked in medicine. In fact, I can accumulate another 5-10 questions also in medicine, but because of the time constraint, I'm not able to do it. So hope you have got the desired result in INI-CET. With this, I'll sign off. Thank you very much.